as we know about the traditional risk factors, normally they are considered everywhere where the risk is associated with cardiovascular disease, but the novel risk factors, emerging new risk factors, and the non-traditional risk factors, they are more important in patients where we get the premature coronary artery disease, unexpected coronary artery disease, where we don't usually don't find any obvious reason for the premature occurrence of coronary artery disease. I will be briefly going through the novel risk factors for cardiovascular disease. As we know that the burden of the disease is almost 7.8 million people worldwide, they die with cardiovascular disease, and this is the third leading cause of mortality worldwide. And death and disability are due to cardiovascular disease is, we know that is preventable. And addressing the risk factors can mitigate the immense healthcare burden as well. The traditional risk factors are all established, but the novel risk factors may enhance the prediction and uncover underlying pathophysiology. As you know, the traditional risk factor, I will not go into the detail of modifiable, these can be non-modifiable, and they can be female-specific risk factors as well, like eclampsia, preeclampsia, gestational diabetes, polycystic ovarian syndrome, and menopause. Again, the traditional or the non-traditional risk factors, both they lead to cardiovascular events and the coronary kidney disease as well. They have different levels like endothelial dysfunction, inflammation of various inflammatory markers, activation of neurohormones. They can have a prothrombotic risk with fibrinolysis or FDPs, and the vascular calcification. These are all associated with the cardiovascular events in premature age. What are the novel risk factors? They can be inflammatory markers, genetic or epigenetic factors, biomarkers of endothelial dysfunction, psychosocial factors, environmental factors, microbiome related factors. They can be inflammatory syndromes like SLE, rheumatoid arthritis, inflammatory bowel disease, and various novel markers like cystatin C and lipoprotein A. Again, we see that the novel risk factors, they can be like sleep deprivations, obstructive sleep apnea, and the various environmental related pollutants and inflammations of different kind. Inflammation and immune related factors, they include the high sensitivity CRPs, lipoprotein A, and interleukin 6. And what is high sensitivity CRP? It detects low levels of CRP associated with the chronic vascular inflammation, and when it is more than 3 milligram per liter, we call it a high risk. And how the CRP is associated with pathophysiologically with cardiovascular disease, it has a role in atherosclerosis, like it promotes endothelial dysfunction, increases expression of adhesion molecules, and enhances uptake of LDL by the macrophages. It can lead to plaque instability or plaque vulnerability that leads to makes the plaque more prone to rupture earlier, and it's also a low-grade inflammation marker. And what are the clinical implications of CRP? There are certain therapies to reduce the high sensitivity CRPs. As we all know that the statins, they both lower the LDL and the CRPs, but the anti-interleukin 1B, canakinumab, that reduces the CRP and cardiovascular events, as it was proven in the CANTOS trial as well. And the current recommendation, they include the consideration of high sensitivity CRPs testing in patients with unclear risk factors. Homocysteine is also independent predictor of cardiovascular events, and it associated with morbidity and mortality. How homocystinemia if causes the cardiovascular events, it can start from the endothelial dysfunction, leading to increased in arterial stiffness, and there may be intimal or medial thickening later on, ultimately leading to the prothrombotic activity. What is lipoprotein? It's a LDL-like particle which is attached to apolipoprotein A, and it's not altered by the lifestyle or standard lipid-lowering drugs. When it is more than 50 milligram per deciliter, we consider at elevated levels of lipoprotein A. It has two components. One is apolipoprotein B100 and other is the apolipoprotein A. How it causes the cardiovascular events? It's like LDL particle, but it leads to pro-atherogenic effects, and it can cause the prothrombotic effects as well, ultimately leading to atherosclerosis, thrombosis, or valve calcification in the end. And what are the treatment lines for treating the apolipoprotein A? Statins, as we know that they are very ineffective in treating the apolipoprotein, but the PCSK9 inhibitors reduce 25 to 30% of the apolipoproteins, and if they are very high and the individual is very high risk, then we can go for plasmapheresis as well. The emerging therapies, they include antisense oligonucleotides like pelacarsen, but it is in phase 3 trials. Cystatin C, as we know, that estimates the exact EGFR, but it's not influenced by multiple factors like habitus, muscle mass, or sex, but it's an independent risk factor for cardiovascular and chronic kidney disease. Risk factor related to thrombosis and inflammation, as we know that interleukins are associated, high sensitivity CRPs, myeloperoxidases, D-dimers. Certain genetic and epigenetic factors also contribute to the cardiovascular events. Genetic variations like PCSK9 genetic mutation may result in progression and early presentation of coronary artery disease. Epigenetics like DNA methylation and histone modification influencing the gene expression. And certain biomarkers for endothelial dysfunction, they may be flow-mediated dilatation, circulating endothelial or progenitor cells, or asymmetric dimethyl arginine, and they need early detection for the vascular dysfunction. The microbiome and metabolomics, they are gut microbia, they produce metabolites like trimethylamine N oxide that is linked to atherosclerosis. Basically, they have a role with the bile acid production. They alter the lipid metabolism, ultimately leading to atherosclerosis and coronary events. And that's why the microbiome profile, potential diagnostic and therapeutic target. There are also environmental and lifestyle factors for the coronary artery disease, like air pollution, but PM, that is called the particulate matter, linked to endothelial injury, but the noise pollution can increase the sympathetic activity, leading to premature coronary artery disease, and diet and physical activity interplay with the genetic predisposition. And air pollution, exposure to increased concentrations of PM 2.5 over a few hours to weeks can trigger cardiovascular disease related to death and MI. And what is PM 2.5? It's inhalable particulate matter of diameter less than 2.5 that is mostly present in second-hand smoke. And the exposure to second-hand smoke more than 2 weeks time can lead to a certain degree of risk. And the high risk population, they are more prone to have these complications with these environmental factors. Then this obstructive sleep apnea is associated with increase in incidence and progression of coronary artery disease, heart failure, stroke, and atrial fibrillation. And 34% in males and 17% in female in general population, the risk with the obstructive sleep apnea. Certain mental health disorder like depressive illness is also related with the MI, stroke, heart failure, and there is with depression 25 to 40% more likely to die from ischemic heart disease as compared to with the patients who are not having the depression. Anxiety disorder, they also have the 70% increased risk of ischemic heart was found amongst cases with the anxiety disorder. And in the end, non-alcoholic fatty liver disease is the most common chronic liver disease in developed countries and estimated to affect 25% of the adults worldwide, double the risk of coronary artery disease in patients with non-alcoholic fatty liver disease. And risk factors for non-alcoholic fatty liver disease, they include the insulin resistance, impaired glucose tolerance, hypertriglyceridemia, visceral adiposity, and metabolic syndrome, and PCOS. Thank you very much.